Hold on. I gotta move the code so that it shows live on the website of Neurosurgical TV.
Dr. Bennett, could you also make Anirudh the panelist as well? I mean, he's
Yeah,
joined, but
yeah, sure.
yeah.
I'm done.
My friend Akash is also here. He's a batchmate of mine, and
Okay.
yeah.
So you should have some familiar faces. Okay, here we go. Okay, 10, 9, 8, 7, 6, 5, 4, NeuroHawk. Man, oh man, I'm forgetting it. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach here, just a couple of miles from 1 mile from here. We have the honor today of televising a prodigy, Little Atoll, a med student that I was surprised to see he's done a bit of publishing, much in the vein of Atul Goel. And uh, it's the name of the platform is NeuroHawk. I'm looking forward to hearing it. And here to help us introduce Naveen is Pratiska Baliga. She's graduated from med school. She's in Mumbai, and she's going to give the formal neurosurgical production of Naveen. Welcome, Pratiska.
Hello, sir. So I'm introducing Naveen Kirti. He's a first degree connection MS3 aspiring neurosurgeon scientist. He's a ACTREC research assistant, a research lead at IEE, ICMR STS 2023 scholar, a review board member at the AS Journal, and he's also had Tata scholarship. And he's going to introduce us about the NeuroHawk. Hello, Naveen.
Hello, Dr. Bennett, and hello, Pratiksha, ma'am. Thank you so much for the warm welcome. And I'm here to talk about the new app, the new web-based application that I've come up with called NeuroHawk. So before we get into it, I'd like to screen share so that I can start with my PPT presentation. I hope it's visible to everybody.
Okay.
Yeah.
Perfect.
Yeah. So NeuroHawk, as you can see, we have set a tagline as ALS steals time and NeuroHawk gives it back. And The reason behind the whole statement might not be clear now, but once we dive into the nitties and gritties of the app, I'm sure everybody would be on board with this idea. So, just a minute. I'm having some trouble with the screen sharing.
Yeah, normally, if you click on the right side of the screen, it goes to the next slide.
Okay.
Okay.
Yeah. So the agenda for today is discussing these points that we have as to what is NeuroHawk, how it originated, and why we are focusing on diffusion tensor imaging, the behind the scenes BTS of NeuroHawk, the statistics behind it, and finally we'll examine the app and along with some conclusions and takeaways for today. So I'm as Pratiksha ma'am has already given my introduction, but just before we dive in, I'm a third year MBBS student at Mimar Medical College with the research spanning neuroscience, oncology, immunotherapy, and neurodegeneration. I serve as a research lead at IEEE Neuromathematics project, where I work on hippocampal network degeneration. And I also serve as a peer reviewer for quite a few journals, including the NEJ, IBRO, a Journal of Spine Surgery, the BMJ Journal of Neurointerventional Surgery, as well as MMG of my own institute. And I have also served as the invited reviewer of IJRSI, as well as the Yale Journal of Biology and Medicine. And I also worked at Bauer's Lab of Neurological Frailty, and along with a lot of other apex institutes of the country. So, what is essentially NeuroHawk? So, NeuroHawk is an AI-powered neurodiagnostic platform designed to predict and interpret structural and microstructural brain changes using MRI-derived biomarkers. So, what it essentially means is that ALS right now, amyotrophic lateral sclerosis, has a few diagnostic modalities that we currently use, but none of it can quantify the disease. None of it can let you know what is the risk of a person developing that disease. So this is why we brought NeuroHawk. So NeuroHawk essentially considers three parameters of DTI or diffusion tensor imaging. For the rest of the discussion, I'll be using the short form DTI. It's easier to pronounce. So it brings together CSA, corticospinal cross-sectional area, FA, fractional anisotropy, and MD, mission diffusivity. So along with that, we bridge in clinical features and machine learning models to generate real-time risk predictions, severity estimates, and clinically interpretable insights for neurological and neurosurgical conditions like ALS. So in short, NeuroHawk is a sharp, fast, and AI-driven decision support system for the brain, built to give clinicians a hawk eye view of diseases before it becomes obvious. Now, I'll get into why we named the whole app as NeuroHawk, but before that, I'll try to get into what NeuroHawk really combats. So, amyotrophic lateral sclerosis or Lou Gehrig disease is the most common motor neuron disease in a group of illnesses that involve both upper and lower motor neurons. This disease is so tragic that once the patient starts experiencing the signs and symptoms, it continuously goes on progressing. There is no definite treatment for it, be it medical or surgical. We currently do not have any specific definitive therapy for the disease. So the landscape of the disease suffers from a lack of reliable and robust biomarkers. And without a reliable biomarker, ALS is a clinical diagnosis supported by laboratory investigations. What investigations, you might ask? There are muscle biopsy studies that we do, there are needle studies that we do, and also muscle elasticity studies that we do to detect ALS and in patients that we suspect of. But it essentially remains a clinical diagnosis. So the global incidence of ALS is 1 to 2.6 cases per 1 lakh person per year. And before I jump into the whole epidemiology of the disease, I get that ALS is a very rare disease that we have in hand right now. Not everybody gets ALS, but people who do have a really grave prognosis. The prognosis is not good at all. And the reason for me choosing ALS, other than any other common neurological disease, such as traumatic brain injury or spinal cord injury or any common disease for that or pathology for that matter, is that I used to attend this medical lecture of mine with my mentor, Dr. Sushant Shinde. And while talking to him about the disease, while he was teaching us ALS, while I was in my third year of MBBS, he told us that Stephen Hawking, the guy, the person who's most famously known for his inventions and also him having ALS, could survive to the age that he survived because the hard truth being he had the financial capability to do so. He had a built-in home um ventilator, and that was the reason why he could survive for so long. But that is not the case for most of the people who suffer this disease. A lot of these people who suffer this disease suffer from a lack of basic amenities. There's a lack of basic diagnosis that happens. So not everybody has the privilege that Stephen Hawking had, but Stephen Hawking is an important reminder of the fact that people with this disease can survive and they can live a long and fulfilling life. So moving forward, the global prevalence of ALS is 4 to 6 cases per 1 lakh population. Sporadic ALS, or what we would like to call SALS, is 90 to 95% of all ALS cases, which makes this disease even more dangerous, quote unquote dangerous of sort, because there is no the genetic testing essentially only covers 10% of the total population. The familial ALS, or FALS, that is usually called as, it's 5 to 10 percentage of the entire cases. The median survival after symptom onset is 2 to 4 years. This essentially shows how deadly the disease is, and a 10-year survival rate is less than 10% patients. So essentially, if 100 people have ALS, there's a 10% chance, there's a mere 10% chance that out of those 100 people, only 10 would survive for the next 10 years. So diagnostic delay is typically 9 to 12 months. So essentially, after the disease progress starts, it's said that there's around a delay of 1 year before the person is diagnosed with ALS. Now, some might argue that early detection of ALS might not be of help because the ALS is going to take its due course, but at least we can prevent FALS or SALS for that matter, and reduce the burden of the disease in the population. The projected rise in global ALS burden by 2040 is about 25% increase due to aging populations, because it's a disease of the elderly. So what these numbers mean is that even though ALS is a rare on a per year basis, the fact that it's fatal within a very few years or even months for that matter makes it devastating for patients and families. The overwhelming majority being sporadic means genetic screening alone can't reach most cases, which is what I spoke about earlier, highlighting the need for biomarker based or AI driven diagnostic support tools like NeuroHawk. With global aging and care improvements, the absolute number of people living with ALS will rise, because when we read community medicine or public health as doctors, we come across this concept of population aging, where with increase in the modalities and increase in therapeutic facilities that happens, what happens is that the number of people living in the bracket of the aged community, which is considered to be above 60 or 65 years of age, considerably is increasing explosively, exponentially. So the number of people who are elderly is just going to be increasing in nature. So, which also is a huge risk factor for ALS, hence the need for NeuroHawk at this time. Short survival means early detection and risk prediction tools are especially valuable. Detecting ALS earlier may open the window for better care, planning, and inclusion in clinical trials. And this could also help us in research and development when it comes to the disease ALS, where you essentially do not know who might get it and when they might get it. So I've just included this picture. I don't know whether it's clear or not, to compare between healthy homeostasis and the lipid hypo or hypermetabolism. Essentially, what I was trying to do is that to show an overview of how ALS really happens. So what really happens is that the cells of Betz, or the motor cells, right from the brain up to the spinal cord, what happens is that they get destroyed. They get destroyed in a linear fashion. So what happens is that above the area of lesion, you get the UMN kind of lesions, and at the level you get element kind of lesions. So both the UMN and element kind of coexist with each other. So why the name NeuroHawk? So NeuroHawk is named as a tribute to Stephen Hawking. I spoke about it. One of the greatest scientific minds to ever live, and a global symbol of resilience in the face of ALS. Where he was diagnosed with ALS when he was at the age of about 20 or 22, at a tender age of 20, where he was aspiring to be one of the greatest astrophysicists of all time. And he still went on to do that. He still went on to achieve his goals, his dreams. But just imagine if his diagnosis would have been made quite earlier, probably by the time he was born, maybe. The question still remains. So, by naming it NeuroHawk, we honor his battle with ALS, his contributions to human knowledge, his spirit of pushing boundaries even when the world said that it was impossible. I would just like to share an anecdote here. When Dr. Stephen Hawking was in his preliminary age of education, when he was diagnosed with ALS, he was told by all of his batchmates and his professors that he would not make it past 40, and that it is not worth trying. It is not worth uh, studying so much when essentially he's not going to live past 40. But he proved all of them wrong. And so that is the motto that NeuroHawk is also based on. We essentially is a tribute to Stephen Hawking. And he's one of the greatest scientific minds to ever live. And so, why the name NeuroHawk? In toto, NeuroHawk carries the legacy of Hawking, turning science, resilience, and intelligence into a tool that fights the very disease that he lived with. So now that the origin part of it and the name is done, I would like to get into how NeuroHawk really works. But before that, I need to convince people in this meeting as to why DTI, why did we use DTI and why not any other parameter. So why diffuse tensor imaging? DTI in ALS or amyotrophic lateral sclerosis uses MRI to detect subtle white matter damage in motor pathways. Essentially, what DTI or diffusion tensor imaging, as to my knowledge, what it essentially does is that it detects Brownian movements in the imaging that we essentially see, and it has a 3D navigation of a sort of the particles, and that's how it portrays the white matter tract or the white matter that is seen in the CNS and any pathology associated with it. So, by using DTI to detect subtle white matter damage in motor pathways, showing decreased FA or fractional anisotropy, increased diffusivity, mean radial and axial, but I'm talking about mean diffusivity here, MD, acting as an objective biomarker to track the disease progression and help with the diagnosis. And also to correlate with the clinical severity, there's a score, the ALS FRSR scores that are usually used, particularly in corticospinal tracts and peripheral nerves like the brachial plexus, revealing microstructural changes beyond what clinical exams show. In clinical examination, you usually see that the patient has fasciculations, he has motor atrophy or she has motor atrophy, atrophy of the thighs, and there is difficulty in swallowing, eating, nasal voice. It essentially differs according to whether there's bulbar involvement or not. But the clinical pictures is a lot heterogeneous than what we would like to believe. So, why DTI in ALS? DTI measures the water molecule movement that I spoke about, the Brownian movements in ALS, and disrupted axons lead to abnormal water diffusion patterns, revealing degeneration. So the key metrics that I have chosen to that we've chosen to essentially study are essentially four, but we are taking three into consideration: the fractional anisotropy, mean diffusivity, and the corticospinal area, or the cross sectional area, means cross sectional area. So FA or fractional anisotropy decreases, indicating that there is less directional water flow, which means that there's loss of integrity in the corticospinal tract. Mean diffusivity increases, showing that there's more unrestrained water movement. So both of them are inversely related to each other. And cross-sectional area as well, because again, when atrophy of the corticospinal tract happens, the CSA is bound to decrease. So as the CSA decreases, the FA decreases and the MD increases, the risk of ALS or of having or developing ALS in the future starts increasing. So diffusion MRI, particularly DTI, has emerged as a very powerful tool for investigating microstructural changes in the brain, providing valuable insights into the ALS pathology. DTI studies in ALS have been done before. I mean, I would not like to say that it's a prevalent form of investigation, but it has been done before, and a lot of studies have been done. So I'm not claiming that what NeuroHawk is doing is novel in terms of coming up with DTI as a parameter to diagnose ALS. But developing a web-based application is something that I'm sure has not been done before. So DTI studies in ALS consistently demonstrate alterations in the white matter integrity, primarily characterized by reduced FA, a measure of the directionality of water diffusion in white matter, WM or white matter tracts. The CST or corticospinal tract is a crucial motor pathway connecting the brain to the spinal cord, shows the most prominent FA reduction in ALS patients. So essentially, why ALS was named as amyotropic lateral sclerosis is because when earlier anatomists were studying the disease, after the death of the patient, while they would do the postmortem autopsy, this is what I read. It was very interesting that while they would do the dissection of the spinal cord, they would see that there's a sclerosis of the corticospinal tract, and this is how they would know that there is a ongoing pathology, and the site of the pathology is the corticospinal tract. So I'll now go on to explain which modalities did we choose and why. So fractional anisotropy, we chose FA or fractional anisotropy because it is the most sensitive marker of microstructural white matter integrity. I came across these three parameters in a meta-analytical study that studied the diffusion tensor imaging parameters and their variations in patients of ALS in comparison to a control population. And I'll be further explaining how we use that meta-analysis to essentially extrapolate our data and create a reference population that we later use to later use for the diagnostic purpose. So in ALS, the degeneration of the corticospinal tract reduces the directional coherence. So FA drops early, that I spoke about earlier, the water direction of water molecule movements. So clinically meaningful, it's clinically meaningful because neurologists already interpret FA routinely. Mean diffusivity or MD reflects overall water mobility increasing when the axons of myelin break down. So it complements FA that both of them are inversely correlated with each other. So if one drops, the other increases. So that is a more sensitive way of looking at it. And it detects the early microstructural edema or extracellular expansion that FA alone might miss, might be picked up by MD. And also the gliosis that is usually seen in such patients might also be picked up. It helps in capturing diffuse non-directional degeneration seen in upper motor neuron pathology. And CSA cross-sectional area, this is the most direct and straightforward parameter that we're using because it gives a structural dimension to complement the microstructural data. FA and MD talk about the microstructural pathologies that occur with ALS that can be routinely seen in DTI. And the CSA or cross-sectional area gives a structural direction to it. ALS causes atrophy of the corticospinal tract that I spoke about earlier as well, and the motor pathways, and the CSA shrinks. Highly interpretable for clinicians, that is the thinning of CST, making NeuroHawk useful in real-world neuroimaging workflows. So now I'll be talking about the behind the scenes of NeuroHawk as to how we came up with the app and how the web-based application was done. Yeah. So what when we had this idea that we had to do something related to ALS and its detection, we as students might not have all of the knowledge that there is to amass in ALS. So we started humble. What we did is that we took a meta-analytical study, and since we also have financial constraints as students, where again funds are quite difficult to get, what we started doing is that we took meta-analysis, systemic meta-analysis, and systemic reviews of uh, published diffusive tensor imaging studies in ALS, and there were controls between the affected group and the test group or the normal, the control of the normal or the unaffected population. And it was performed to extract pool, mean, and variance values of the three key imaging biomarkers that we're taking into account, which is the cervical spinal cord cross-sectional area, CST cross-sectional area, fractional anisotropy, and mean diffusivity. So these are the three parameters that we took. And these three parameters were extensively discussed in a lot of systematic reviews and meta-analysis that happened. So using these meta-analytical parameters as the statistical foundation, a synthetic data set of 500 samples, both ALS and non-ALS, was generated in Python by simulating the Gaussian distribution that matched reported population characteristics. This also is a limitation of our study, that this app is based on synthetic sampling that we have done. Real patient data has not been collected so far. We are testing this on possible suspects of ALS, but we have not still used real patient data, or the real patient data that we're using is too diluted in nature because we have done synthetic sampling using Python coding. By simulating the Gaussian distribution, we're essentially creating a normal distribution curve that is stretched across evenly so that we get equal proportion of both ALS and non-ALS groups. So these values were standardized and used to construct a multivariate logistic regression model incorporating CSA, FA, and MDS predictors. I know all of this might have been too complex for some for a medical fraternity who do not essentially go through maths that often. But I'll try to keep this simple. Essentially, what we did is that we kept a logistic regression model. A logistic regression is essentially creating a trend of data, of how the data progresses, if the data slopes down, if it goes upwards, and how is the distribution of the data. And by doing this, we landed up with a mathematical model. And essentially, it's a mathematical formula for a logistic regression model, where we came up with this formula of P is equal to 1 upon 1 plus e raised to what the B0 plus B1 plus B2 plus B3 multiplied by the parameters. So what this essentially means is that this logistic regression curve takes into account these three parameters that we went through, the CSA, FA, and MD, and it extrapolates it to an n is equal to 500 data set, with 250 belonging to the control group and 250 belonging to the affected group. And this is the mathematical formula that we generated, where the values of B0, B1, B2, and B3 is given here, which essentially correlates to all of the parameters that we went through and the synthetic sampling that we did. And from the synthetic sampling, we got these four parameters. This was essential for us to generate the synthetic data. So this is how we have represented the formula by substituting the values of B0, B1, B2, and B3 respectively. So now the P here stands for probability. So at a probability of 0.9 or at 90% probability, or a better way to put this would be, we are 90% sure that the result generated by NeuroHawk is true. So at a value of 0.9 or 90%, we calculated the synthetic data. So that any value that is put into the software and any percentage of probability that you get is 90% accurate in nature. So we kept the area under curve as 90%, and that's what we got later as well. So the final model produced these coefficients, and we got a logit cutoff of 2.197, which is maximized specifically for ALS detection. So this is the Python coding that we did. I've just included a screenshot of it as well, because I was breaking my head over how to do Python, and my colleague Anirudh is the one who helped me code at a lot of parts and at places where I was really stuck. So before we jump into the whole examination part of ALS of NeuroHawk, these are the statistics that we derived. So the ROC curve, or responder operation curve, was used to evaluate the discriminative performance of the logistic regression model, essentially to see, does NeuroHawk accurately differentiate between who is diseased and who is not. So is that probability quite sensitive and specific enough? So ROC curves, essentially what they do is that they talk of trade-offs between the sensitivity and specificity, as to is if the sensitivity is more, the specificity would be less, and vice versa. So we try to maintain a balance with the synthetic sampling that we did. And with the curve that you see here, the area under the curve corresponds to 0.9, which validates the robustness of the model at the chosen high specificity operating point, which is clinically appropriate for ALS screening. So the KDE plots of CSA highlights the distributional overlap between the ALS and the control groups. I agree that it is not exactly coinciding with one another, and that is because we wanted the synthetic sample to be as close to the real data as possible. So this more density representation reinforces the rationale for using high percentile thresholds rather than mean-based cutoffs. So principal component analysis, or PC analysis, this is one of my most favorite graphs that I usually try to incorporate into each and every paper that I try to write or try to work on. So the PCA reduces dimensionality while preserving variance, enabling visualization of the group separation in the 2D space. So the orange data that you're able to see, points that you're able to see, is that of the ALS group, and the blue that you're able to see are of the control group. And you can see that there is a merging of sort in between the both of them at a 2D and 3D space. So the PCA biplot demonstrates that ALS related variance is derived by a combination of these three factors. So it is also driven by these three factors, which what it essentially means is that you cannot use only one parameter to say that this person has ALS, this person does not have ALS. You need at least 3, 5, or the more the parameters the better, but it gets more and more complex to code, to derive the data, and to compute the data. So we stuck with 3. So these at least 3 parameters we feel are more important to at least say with a bit of accuracy that this person has ALS and this person does not have ALS. So finally, the variant plot visualizes the full distribution of MD values by ALS status, combining density and summary statistics. It highlights that increased diffusivity and distributional skewness in ALS patients, this skewness that you see above and below, it is consistent with the axonal and myelin damage, which essentially means that ALS patients do have these MD, FA, and CSA changes that you tend to see in these patients. So this is finally a box plot that we came up with again to show that our model does work in real data patient data settings as well. These visual differences support the biological plausibility of the model and emphasize disease-related structural degeneration, which essentially all of these graphs that I just showed right now, be the violin plot, be the PCA analysis, be the KDE plot, or the ROC curve, what they essentially mean to say is that we are NeuroHawk, the app that we have developed, is able to predict, or I should say, differentiate quite accurately or quite confidently that this patient might have ALS and this patient might not have ALS based off on the diffuser tensor imaging parameters that we would obtain from MRI imaging. So now that I've gone on and on and on about the statistics and how NeuroHawk came into being and the data that we used and how we did it, now it's time to basically show you all the app itself on what NeuroHawk really is. So just give me a minute. I'll open the app as well. I'll now be showing the app to everybody. Just let me share it once. Yeah. So I'm hoping it's visible. Yeah. Is it visible, Dr. Bennett?
Yeah, it's been.
Yeah. Thank you. So this is essentially NeuroHawk that I was talking about all this while. It's a research-backed AI advancement in ALS assessment. So NeuroHawk employs a novel machine learning model. It is akin to what you see in Gemini AI or ChatGPT. That's essentially the AI model that we were going for to analyze spinal cord MRI metrics to offering a crucial step towards evidence-based medicine in early ALS evaluation. So we design this app in such a way that any user, and usually we want researchers, students, as well as doctors to use it. It should be user friendly. That's what we had in mind. So from research to clinical insight, we have these three USPs that our app offers. Essentially, you enter the quantitative metrics, you analyze it, our model analyzes it for you, and you receive the evidence-based results based on the data that we have in hand. So this is the home page. And now you'll either have to sign up or log in into the app. But since I have my email ID already registered, so I'll be logging in and showing you how it really works. So here is my mail ID and my password. So I'm signing in. Yeah. So as you all can see, yeah. Just a minute.
No
Yeah, is it
patient selected.
Yeah. So is it visible? Is it visible? Yeah. So
You haven't selected a patient. You can see what I
Yeah.
can see, right?
yeah.
Okay. Where do you want to take us?
Yeah. So essentially what you all might be able to see at the screen right now is that you have a patient column at the left hand side. I'm supposing it's my left hand side. So I'm essentially entering a patient data, or I have one already in hand so that I can show everybody how it works. So this is
Yeah.
patient ABC that I've entered.
Okay.
So I select this patient
You
ABC.
may have to sign in first. You may have to sign.
You will have to sign in first, Dr. Bennett. But I've already signed in just for
Okay.
for the ease of showing, just for ease of
Okay.
showing everybody how this app really works.
Okay.
So I have this patient ABC with me. So if you can see here, you can follow my cursor tip. The patient ID might be given. There's essentially an entire ID that is given. This was essentially done because data confidentiality is really important. It is a matter of great debate that nowadays happens, that whether patient's data is confidential or whether it's being shared to third parties or not. So we wanted to make sure that the patient data remains confidential, because the doctor will also, or the researcher, or anybody who's using the app will also be including case notes of the patient here. So we had to make sure that the patient data remains confidential. So every patient here, I have taken patient ABC for example, will have a certain patient ID. Below that, if you see, there is a space for case notes where I can record private clinical observations and notes for the patient. For example, if I may type here the name of the patient, the age, or patient history. Yeah, so this is how you enter case notes using your keypad, and it has a good limit of 5,000 words, so you can enter up to almost all the case data that you deem fit. Okay, so once that is done, so I'll show you, there are already predictions that I've done for this patient. So but I'd like to show you how it's done from scratch. So near the patient ABC, you might see this space called new prediction. So once I click the new prediction, I have these certain values in front of me. These are the average values that a patient might have, that a normal person has, with a CSA of 75.4 millimeter square, FA of 0.65, and MD of 0.0011. Okay, so now what I'll be doing is that I'll be playing around with it. I'll be reducing it, increasing it, to show how this app really responds to changes in data. So let's say I'm putting this at 56.0. This app does occasionally have bugs, so I apologize if that ever pops up in between. So the FA, I'm keeping it as 0.55, and the mean diffusivity is I'm keeping at 0.09. Okay, so it will, if you are going way above or below the essential range that a normal human being might have, it will always tell you. So now that I'm within the ranges that a patient might have, I'm asking it to predict. So now it's with the data that I've given. It's random data. I do not know if the patient has ALS or not. I've just entered in random data, and this is the prediction that it has generated. It is said that the probability of the patient having ALS with the MRI metrics that I've just inserted is 0.2%, which is unlikely. There's also a note given below that you could not generate a recommendation due to service error. That is essentially because we want this app to be a supplement to what doctors essentially do, but not replace it. Because again, a clinician's clinical perspective always remains at the highest regard. This is just an helping tool or a helping hand or an aid that you might, that as you may call so, to help the doctor in the diagnosis as well as prognostication. So now I'll close this space. Now I'll go below, and if I go below, you will see a graph here of probability over time. So essentially, I have entered MRI parameters of the patient over a series of time. This shows me entering data at December 4th, 8th, 15th, and at the time when the app was really made. So at December 3rd, 4th, 8th, 15th, 15th, these four periods of time. So as you can see, the graph is sloping downwards. So what this probability over time graph essentially does is that if I'm taking serial DTI MRIs of the patient, it shows whether the probability is increasing, whether the probability is decreasing, or if it remains at the same place. It does not increase or decrease in nature. That is there. And it shows below, now this is a recent update that we added, that it shows individual data trends, the individual trends of CSA, individual trends of FA, and individual trends of MD respectively. Why is that so? That's because the whether it be CSA, FA, or MD, it individually shows whether there's an individual risk of one of these parameters going haywire once the MRI scans are being done. Like initially, the CSA might be normal, the other CSA might be normal, FA might be normal, but MD might be sloping downwards, it might be increasing upwards, or there might be just one parameter that's increasing or decreasing. So to essentially have a bird's eye view over all the parameters in hand, we have this separate FAMD and CSA trends as well, along with the probability over time trend that we have. So now below, now that we've discussed the first two, which is the probability over time graph, the individual graphs, I'll come to the prediction history part of it. This is where things get interesting, or this is the part of NeuroHawk that excites me the most, where we have these prediction histories. Now you can see I have entered the MRI details of the patient at these dates, December 3rd, 4th, 8th, 15th, and again at 15th, at these particular periods of time. That's at 10:55 a.m., 12:53 p.m., and all that. So it essentially gives you an idea of when all did you record the MRI of the patient and when all did you enter the data. And next to that date column and time column, there's this probability column where if you can see on December 3rd, it showed that there was a 3.5% probability. On December 4th, this is just an idea that I'm giving. On December 4th, show that it had a 5.4% probability. And so far, I had entered in random data to see whether the model works or not. But this is essentially how it is supposed to work with a patient as well. So there's a probability section. And next to the probability section is a classification, whether it's likely, unlikely. And in this particular patient, if you see, all of the classifications that you see here are unlikely. So a patient is essentially safe, according to NeuroHawk. So next to the classification part of it, there's separate columns for CSA, FA, and MD respectively. So you can see the data that you entered for CSA, FA, and MD, and you can also look at it. You can see the trend yourself without having the graphs as well. Now, next to these, all of these columns is the most important column that you can see that I'll circle around for you is the actions column. Now, why is that important? Now, I'll click on any of these actions. I'll click on this, for example. Now that I click on this, it essentially takes you to a page called the prediction analysis page. You can go back to the patient as well. It takes you to the prediction analysis page. So below the prediction analysis, if you see, comparing prediction dash against reference data set. So the dash here, the long name or ID that you're able to see is the ID of the patient. So here the name of the patient is not being revealed. This is what we wanted to make sure. So we're essentially comparing the details of this patient ID against the reference data set that I spoke about, that we took from a meta-analysis. We did the synthetic sampling using Python coding and all of that. So after comparing it with the reference population that we've entered, we'll again be updating the reference population as and when we go. Now the app is not even 15 days old, so we only have synthetic data. But now, now that we're getting funding, we are in talks with Macquarie University from Australia, and they're ready to fund the other half of the project, assuming that we might have a lot more reliable patient data set with us. So right now we are taking the reference data set as as a word of truth. So once that is being, the data set of the patient is being compared with the data set of the reference group, you can see these input metrics. The input metrics that I put so far. What did I put? The CSA was 60, the FA was 0.43, and MD was 0.0021. This is what I had entered at that point of time. And next to that is the prediction. It shows that the prediction is highly unlikely. That is unlikely. There's only a 0.2% chance that the patient might have ALS. And next to that is the percentile population percentiles. So what that essentially means is that the CSA and FA and MD of the patient, what is the percentile of it in comparison with the reference population? Where do you really stand? Where does your patient really stand in comparison to the general population? Is he or she at a higher risk? Is he or she at a lower risk? That is what the percentile population percentile is for. This is also done in competitive exams where you're given percentile to see where you rank among your peers, whether you're first, whether you're second, and the guy who tops essentially has the 100th percentile or the 99th percentile, and everybody is compared to his high score. So here also the same thing is happening, where the population percentile has been given the 100th percentile, the MD essentially, and the other percentiles are being compared with the 100th percentile of the reference population. So below that is the recommendation page. We're still working on it, and right now we have not included the recommendation page because this is still working on a synthetic data set. Once the synthetic data set is extrapolated and we include a real patient data set as well, we tend to expand the recommendation area as well. So now below the recommendation area, if you see, there are three various parts. That is, the CSA is compared with the FA, the CSA is getting compared with the MD, and the FA is getting compared with the MD. Essentially, all the three parameters are getting compared with one another. You might ask, why is that important? That is important because it essentially offers researchers and doctors a holistic point of view, a holistic overview at what data you are essentially looking at. The physician sitting at a hospital does not care for how this app really works. What the physician essentially wants, is what I'm assuming, is that the patient needs to be helped. and he needs a decision making or a clinical aid tool that might help the clinician in making the decision and in the prognostication of the patient, and that's what this does. This essentially provides a view of where the patient really stands, the date or the metrics of the patient really stand. So if you see the star mark here, the star mark is that of the, I apologize, the star mark is that of the patient, and all the other data sets that you can see so far, the red or the green, is that of the reference population. So the reference population is being compared to, and the star mark that you see is that of the patient that you've just entered. So if, as we can see in the second and third graph on the right side, the star mark is way above the data set that we are looking at, which essentially shows that the patient does not fall in the danger area or the high risk area where the patient needs to be evaluated much often. So we can essentially evaluate the patient much less often, and we can look and so essentially a risk stratification can be done among patients. So that was it. This is the advanced data page, and I'm going back again to the area where no patient was selected, and you can essentially enter data, and I'll even show for example, this is patient MNO. If you enter that as well, that gets added. See, now the patient MNO has gotten added. So now patient MNO has a new patient ID that has been assigned to him, and these are case notes. And you can, again, there's no P probability over time or CSA or prediction history, because we haven't entered any data for him or her so far. So this is how NeuroHawk essentially works. And now I'll be logging out of this. And this is the login page again. And if I reload the page back again, or if I press back at NeuroHawk, we come back to the dashboard. So that was right there. I hope I did a decent job at explaining what NeuroHawk really does. Now I'm stopping the screen share, and I'll be sharing the rest of my PPT. Yeah, I hope that's visible. So yeah. So essentially, yeah. So in conclusion, NeuroHawk integrates FA, MD, and CSA to capture the complete spectrum of ALS-related corticospinal tract degeneration, where we are bridging the clinical pathogenesis, the pathophysiology of the disease, along with AI and ML that's coming up. And before I finish with the conclusion, I would also like to address that AI and ML is a hot topic right now. It's usually debated whether AI and ML will take over what doctors really do. Will AI ML replace what doctors essentially do? Will AI and ML turn out to be a better alternative than what doctors are doing right now? But I am a firm believer of the fact that AI, ML, and doctors, when they join hands with each other, it will lead to far greater outcomes than what either of them can achieve. And also, a clinician who has trained years and years looking at patients, looking at their symptoms and diseases, is far more competent at knowing what the patient has, rather than any AI ML model. So this AI ML model, NeuroHawk, is essentially a clinical decision tool to aid the doctor, not to replace the doctor, not to replace the diagnosis of the doctor, not to challenge the diagnosis of the doctor, but to help the doctor in making a clinical decision. So once now that's made clear, FA detects early microstructural loss of fiber integrity, MD identifies diffuse axonal breakdown and extracellular changes, and CSA quantifies the structural atrophy that clinicians can readily interpret. By combining these three complementary modalities, NeuroHawk achieves a balanced, biologically grounded, and clinically meaningful representation of disease severity. This triad forms a robust foundation of accurate ALS prediction, early detection, and real-world neurosurgical and neurological applicability. So final takeaways is that NeuroHawk uses strongest DTI triad, the FA, MD, and CSA, that we've gotten by analyzing various meta-analyses that are there in medical literature. I'm not saying all of them, but majority of them, and capturing microstructural diffusion and structural degeneration in ALS. If it picks up early corticospinal tract damage, your earliest biomarker signal, MD, reveals axonal loss and extracellular changes that FA alone cannot miss. So FA is the earliest one, MD complements FA, and CSA provides a structural atrophy picture to these microstructural data that we have been constantly talking about. So together, they form a comprehensive, clinically relevant ALS signature. This multimodal approach gives NeuroHawk its diagnostic accuracy, biological validity, and translational strength that we're aiming for. So before I end the demonstration of NeuroHawk, I would also like to say that there are certain limitations that are associated with NeuroHawk. The primary one being that we have used synthetic samples so far. Synthetic sampling, while reliable in nature, cannot be cannot be used on real patient scenarios. The reason being that again we need real patient data for it. So once we get the required funding for it, once we talk more and once we amass more and more clinical data, and we progress with the development of this app, we are aiming for making sure that this app does perform wonderfully in patient settings as well. So a huge thank you to my parents, friends, and all of my well-wishers. And this wouldn't have been possible without the constant support of all of my friends, Anirudh, Mayank, Suhani, Akash, Richard, and all of my other peers who constantly helped me with the whether the ideas that seem crazy at first or be it anything else. I owe it to all of them. And also a huge thank you to Dr. Bennett, the man, the myth, the legend, the founder of Neurosurgical TV. He's the reason why I'm able to talk about my platform on such a on such a platform that is global in nature. So a huge thanks to him as well. Yeah, thank you. I'll stop sharing now.
Okay, Pratiska? Pratiska?
Yes, sir.
Okay, thank you very much, Naveen. I wouldn't call myself a legend, for sure. Now, with Tool, he's a legend. Okay, any comments or questions from the panel?
Yeah.
And ask anything, don't be afraid. It's the platform meant for interaction. And the sooner you get more comfortable, the better. Okay, I guess we'll go to Pratiska for a question.
No, sir, I don't have any questions.
Okay. Okay, thank you very much, Naveen. I'm sorry, I wasn't
Professor
really
John.
watching it. I was promoting it. However, this would be a good.
Dr. Bennett,
Or-
I think somebody's trying to speak actually. I'm not sure.
Okay.
Is somebody
Professor
trying
John,
Oh, I'm sorry.
good morning. Yeah.
Go ahead.
Hello, I'm Suresh.
Yeah. Hello, sir. Yeah.
Yes, go ahead, Suresh.
Since I'm a neurosurgeon, I'll not know much about the ALS, but I just wanted to know that what are the chances that this can diagnose the neurosurgical diseases earlier than clinically we diagnose? And can it predict the prognosis in those diseases? And does it have any value in the traumatic brain injury and spinal cord injury? Naveen.
Yes. Thank you, Dr. Suresh, for your question. So essentially, Dr. Suresh, I'm assuming that DTI is to look at white matter pathology, right? So be traumatic brain injury or traumatic injury to any part of the CNS, there is going to be either gliosis or injury to that part of CNS. So this model can be translated to traumatic brain injury as well, or to any such neurosurgical pathology. So I'm sure a clinician is probably as fast or faster than AI at detecting be it TBI or be it any other pathology for that matter. But what AI essentially does is that once you feed in data of I'm taking TBI as an example here. So if you essentially feed in the data of TBI, be it CT or MRI or DTI for that matter, you use that in traumatic brain injury. You train the AI model to detect TBI using the patient metrics. It might so happen that in the future, or in the very near future, we might have a certain AI ML model that can predict traumatic brain injury way before clinicians or conventional methods of diagnosis can
No,
predict.
no.
And it could
About the traumatic brain injury and spinal cord injury, I just wanted to know about the prognostication.
yeah,
But
yeah,
about the other intracranial neurosurgical diseases,
yeah.
I wanted to know that could the FA and CSA,
Yes.
detect the things earlier than what we clinically detect?
Right.
Is it possible?
Yeah, I mean, I'm not as experienced to make claims here, but I'm sure that it can do so, Dr. Suresh, because it has been tried out before and in play. And I just to explain the answer better, I was recently a part of the Stanford University in the PNT lab, the Precision Neurotherapeutics lab, where they were essentially working on the same idea that you and I are discussing right now. They were using MRI parameters to train an AI ML model to for not only prognostication but also earlier diagnosis of brain internet.
That's what I am interested. Yes,
Yeah,
that's
yeah.
what I am
So,
interested in.
yeah. So
Earlier
that is
diagnosis.
yes, Dr. Suresh. That is being done actually, and that is our aim as well. Because essentially, be it ALS or be it any other CNS pathology for that matter, earlier detection is what we're looking for. The earlier we detect the condition, I'm assuming the earlier we can treat.
Yes,
The earlier we can treat, the better the chances of
yes.
survival.
Do you have
Yeah.
any references to that? If you have, then I can go through those.
Yeah,
Earlier detection.
right now I do not, Dr. Suresh. I mean, if we could get in touch, I would surely love to send it to
You
you.
can
But right
forward
now,
it to me, Professor John, and he'll forward it to me.
yeah,
Okay.
sure, Dr. Suresh. Yeah.
Okay, nice. Thank you.
Thank you so
It's
much,
a
Dr.
really a
Suresh.
new arena you have opened up, and it is going to be definitely useful for early diagnosis and prognostication of ALS perfectly, and maybe the other conditions also.
Yes. Thank you, Dr. Suresh.
Yeah, thank you,
Thank you.
Suresh. That's why I was kind of excited to see to look into your project because I really haven't seen the growth of a platform. What does one do? How does one develop it? So, what are your next step in your developments of your project?
Um, Thank you for the question, Dr. Bennett. So what we essentially plan on doing right now is that what the whole basis on what ALS on what NeuroHawk is based on is synthetic sampling. And while synthetic sampling is a efficient is a good alternative for real patient data, it cannot replace real patient data. So what we are trying to do right now is that we are trying to screen real world patients, I mean actual patients whom we are suspecting of ALS with fasciculations, be it tremors or any other bulbar palsy or for that matter. We are trying to take their DTI parameters, actual DTI real world parameters, and try feeding them and training our AI model better. So now the AI model will not just be reliable, it will also be accurate because now it's being trained by real patient data. So that's our next immediate goal. Is that we want to train the AI ML model with real patient data, with real patient DTI parameters, not just DTI parameters that has been synthetically generated using Python or any mathematical model. We want it to be as real to the wards as possible, as real to as close to the patient as possible.
Okay, great. So we look forward to following you in your development of this project because
Yes.
you're really the first one I've run across that's developing it from an early stage, and it'll educate the audience on how the project of this would develop
Yes, doctor.
normally, organically, what happens. So appreciate you coming out and putting hopefully this webcast on your resume, your video resume of your project, and just let your community know that we'll be following you.
Yeah, and thank you so much for the opportunity, Dr. Man. It means a lot to me. I mean, I've been trying to reach out to people, try on my way building networks with other neurosurgeons, and climbing out of the rabbit hole essentially. And you doing this for me actually means a lot.
Well,
Thank you so much.
it's a pleasure because it shows what video platforms can do. They can advance projects like this. They can let people know what's going on and
Yes.
bring light to the
Yeah.
areas of darkness. So we appreciate it, and we look forward to talking to you in the future. And thank you for the
Thank you,
hostess,
everybody.
Pratiska. Thank you.
Thank you.
Okay, we'll
Thank
see
you.
you again. Hang around.
Yeah.
I'm going to sign off, but hang around. Okay, yeah, so that was good. Good intro, Naveen. It's just a start. Uh, and yeah, I want to educate myself with what happens with something like this because everyone starts somewhere.
Yes.
Uh, and it's good to hear, you know, the next step and what you do to make it known to the community. I tried to get a hold of OptiKey. Is that the name of the platform for ALS people? You probably didn't look into it, but I did a webcast. Here,
Okay.
let me show you. Just give me a
Yeah.
second here.
Yes, Dr. Bennett.
I think it's called OptiKey. I did an interview with this gentleman from England. Uh, it's called OptiKey. There we go. It's OptiKey. Okay, let me share this here. Yeah, I don't know. This was you can't hear that, right?
Yeah, I've actually gone through this, Dr. Bennett. I mean, you told me to go through the actually all the
Yeah,
ALS related
this is
platform.
a webcast we
Yeah,
did
yeah,
with a neurologist from
yeah, yeah. This was
Spain.
quite inspirational, actually.
Okay, so you did see that video?
So, what I essentially took from the video, Dr. Bennett, that I mean, a lot of people are essentially working towards the same goal,
Yeah,
even though
I'll send you the original copy.
yeah,
But he
yeah,
basically he was he's not a doctor. The gentleman from England, he's a programmer, and
yeah, yeah,
he started this to help ALS patients communicate
yeah, yeah,
by blinking of the eye, I believe. That was his main premise, that you can use blinking of the eye for a patient to
yeah,
to
yeah,
communicate, to interpret
yeah,
what it does.